Ortiz for today. As most of you know, Dr. Ortiz is the Director of Laser and Cosmetic Dermatology and an Associate Clinical Professor of Dermatology here at UC San Diego. She completed her dermatology residency training at UC Irvine and Beckman Laser Institute. She then went on to receive training in Mohs micrographic surgery here at UC San Diego, and also completed the prestigious Cosmetic and Laser Fellowship at Massachusetts General Hospital, Harvard Medical School, and Wellman Center for Photomedicine. She has authored over 60 publications and several book chapters. Dr. Ortiz has presented at international and national conferences and is frequently an invited speaker at the American Academy of Dermatology, American Society for Dermatologic Surgery, and the American Society for Laser Medicine and Surgery. She is on the editorial board of the Journal of Lasers in Surgery and Medicine and has won several awards, including the Top Doctors Award and Exceptional Women in Medicine, as well as the ASLMS Best of Session Award for Cutaneous Applications and Research Grants. Dr. Ortiz has also served as the president of the San Diego Dermatologic Surgery Society and is currently president-elect of ASLMS. Her presentation today is titled Expert Techniques for Combination Treatments in Aesthetics, Injectables, Energy-Based Devices, Topicals, and Oral Supplementation. We're so excited to hear you speak. Thanks so much.
Thank you so much. Thank you for that kind introduction. And I'd like to make this as valuable for you as possible. So please, let's make this interactive. Just stop me if you have any questions along the way. These are my disclosures. So I'm going to be discussing a combination approach to aesthetics today. We'll start with rejuvenation. So I know we talk a lot about modalities individually, but in real world, we're commonly using them together to optimize our results. So when we're talking about rejuvenation, you want to address volumization, you want to address wrinkles and lines, dyschromia and texture, laxity and gels, and so we'll review that. So what kind of procedures can be combined on the same day? Most procedures can safely be combined on the same day. The only procedures I would caution would be like neuromodulators with laser, anything that's going to cause any kind of inflammation, because if the toxin migrates to a muscle it shouldn't go to, then it can cause swelling. So I just separate these procedures by 24 hours. So one day is enough, just not on the same day. And maybe you might get away with it 99% of the time if you did it on the same day, but I don't want to deal with any kind of ptosis. I like to sleep well at night. So I just tell patients you might get a droopy smile for a couple months. So just come back tomorrow. So you can combine injectables with laser, like you can combine like filler, but like I mentioned, you don't want to use toxin on the same day. But if you do filler on the same day, I would do filler first and then do laser, because you might get swelling from the laser and then that'll distort your need for filler. So I do filler and then the laser. You do want to use neurotoxins prior to like aggressive resurfacing, because it has shown that you can improve the results. For example, if you're using like ablative resurfacing and the patient is kind of contracting their muscles and recreating those creases as they heal, then you're not going to get as good a result as if they're relaxed and not recreating those creases. So a week or two before the laser procedure, I will treat with neurotoxin, again, not on the same day. So this is an example of a patient who had serial neuromodulators and then fully ablative erbium. And you can see that you get more improvement if you combine the two than if you were to do one or the other just on its own. So for laser resurfacing, you can consider fractional resurfacing versus traditional fully ablative resurfacing. So it's going to depend on what the patient is looking for and what fits their lifestyle. So there's going to be less downtime with fractional resurfacing, but you're going to have more modest results versus someone who has more downtime. They're going to get more dramatic results, but traditional resurfacing is usually for patients who are retired, who have more downtime, because it is, you know, a significant investment in healing. It takes like 3 months. And so you want to consider what works best for your patient. If you're going to resurface around the eye, you need to know how to place corneal shields. So anything within the orbital rim, you must have corneal shields. And I do use injectable lidocaine in this area. I don't use a topical anesthetic on the eyelid because if it gets into the eye, you can cause a chemical corneal abrasion. Nothing happens permanently to their damage, but it is quite painful, and that can last for 24 to 48 hours. So I use injectable lidocaine in this case. So here I'm showing you how to place the eye shields, and I'm using proparacaine anesthetic drops. There's no preservative, so it doesn't sting, versus tetracaine stings more. And then I'm using erythromycin ointment under the shield. I kind of slide under the upper lid and then pop it under the lower lid. Make sure there's no lashes that are tucked in because that can cause corneal abrasions as well. So here I'm using fully ablative resurfacing, using the erbium laser. And so I like the eye shield with the post because then you know exactly where the eye shield is. Just because your eye shield is in doesn't necessarily mean the eye is safe. You want to make sure that the eye shield is covering the area that you're treating. So when I'm treating the eyelid skin, I do use coagulation, which can be modified on the laser because it helps to kind of tighten the eyelid. And so here's an example of fully ablative resurfacing using erbium and then in combination with a neuromodulator. So the question is, when do you refer someone to a blepharoplasty versus resurfacing around the eye? And usually it would be like if the patient has good quality skin, but it's redundant, then they might be a better bleph candidate. But if they have poor quality and crepey skin, then they might do better with laser resurfacing. But then the patients who tend to come to me just don't want surgery. And that's another thing to consider is sometimes patients are just scared of surgery. And so they'd rather do laser. And so this is an example of neuromodulator, filler, and fully ablative erbium. So you also want to address the volume loss in the tear troughs. So when you're using filler in this area, you want to use a low G prime filler. If you try to use something that's too thick, it's going to look lumpy, it'll tindle. So use something with a low G prime filler. You can use cannula versus needle. They're both good techniques. It's really just your preference. And here's an example of the cannula technique. I'm not sure why the video is shaky on this, but so I'm using a 27 gauge cannula. You can use a larger cannula if you like, but they can be a little bit more traumatic. And then here's an example of before and after with just filler alone. Before and after just filler. And then this patient, again, was a better bleph candidate, but most patients who come to me just don't want surgery. So you can still get improvement with filler alone, but it's not going to be perfect correction, but she definitely looks better than what we started with. So moving on to perioral rhytids, you want to identify what type of perioral rhytids. Are they just, columns that occur with animation? So in that case, you would consider neuromodulators. Are they more etched in? And then in that case, you could use filler, or do they have more cobblestone texture, which probably would do better with laser? So when you're addressing dynamic perioral rhytids, you can use a neuromodulator, and I do 1 unit at each injection site along the vermilion border, and I don't do more than 6 to 8 units total. It can affect their phonation, so most patients will complain that if they're like brushing their teeth and they try to spit, it's difficult to pucker, or when they use a straw. So you want to be careful in musicians or singers because it can affect their work. And it's usually more of an issue in older patients. Younger patients don't have difficulty with this, but I always mention it so that they know. And this is what's commonly called like the lip flip. So it's the same thing as lip flip or treating perioral rhytids. The technique is the same. And then if you want to combine this with resurfacing in this area, I don't use any coagulation because it does increase the risk of scarring. So here I'm using erbium and I'm doing 100 microns per pass. And so I'll do a couple passes depending on like how much cobblestoning they have. So in this case, I think I did 3 passes, which would be 300 microns. In between each pass, and you'll see me do this in a second, you want to wipe with saline gauze because if you fire over char, it's going to increase your risk of scarring. So I just remove the char with each pass. And then I'm using a smaller spot here to kind of whittle away at each rhytid. So you just kind of sculpt them away. And then when you see this pinpoint bleeding, that's your endpoint because you know you're in the papillary dermis. And so you don't want to go too much deeper than this. And oh, go back. So this is what the downtime looks like. So they're pretty oozy, bloody, crusty for about 2 weeks. And then they stay red for 3 to 4 months. So if they're planning for something like a wedding or an event, it's important that you plan this well ahead of time because it is prolonged, as I mentioned. So because their epidermis or their epidermal barrier is disrupted, there is a greater risk of infection versus fractional. So one thing that I use as a sign of infection is pain. Surprisingly, these patients are not in a lot of pain when they're healing. So pain should decrease. Any increase in pain is always a sign of infection. Bring them in right away, culture them, and start prophylactic antibiotics. So if they call on day 3 or 4 and they're like, I was doing just fine, and now all of a sudden it's really starting to bother me, that's always an infection. So I will give them doxycycline and valcyclovir as prophylaxis. So if they break through that, then generally it's a gram-negative, and I'm usually starting something like Levaquin. You also want to think of like itching. Itching is normal through the healing process, but like significant itching, you might want to think of like a candidal infection. So I'll culture for both if I'm suspicious of candida. But because their epidermal barrier is disrupted, infections can spread quickly. And so you want to consider IV antibiotics if they start to become symptomatic with like fevers and chills. So this is an example of pre-treatment with a neuromodulator and then fully ablative erbium just around the mouth. So it's not like every single wrinkle is erased, which sometimes patients are hoping for, but she's significantly better and was very happy. Here's another example. And she actually got an infection, did well, didn't scar, but you can see the erythema is prolonged because of the infection. And this is a combination of filler, neuromodulator, fully ablative erbium, and you can see some nice improvement on the cheek rhytids, which is really difficult to do with fractional resurfacing. So sometimes you really need fully ablative to get these dramatic results. And I like this video of fully ablative resurfacing because you can actually see the contraction in real time. So even though we think of resurfacing as more for like wrinkles, you also get some nice tightening with it. Okay, so addressing the platysmal bands. So as we age, the platysmal bands start to create these like linear bands down the neck. And so you can treat that with botulinum toxin. So I usually keep the dosing, if we're talking about Botox, Xeomin, or Jeuveau, I keep it to less than 40 units because if you use high doses, it can cause dysphagia. So I'll have them come back at 2 weeks, and if they need more, then I'll do it in a second sitting. But in one sitting, I try to limit it to less than 40 to avoid any kind of dysphagia, which I've never seen, but it is possible. And so each injection point is going to be about 2 to 4 units per injection site, and you do like 3 to 4 sites along the band. So as we age, the platysma pulls down on the lower face. If you also treat the attachment of the platysma along the mandible, then it helps to sharpen the jawline and improve the contour. And so that's called the Nefertiti lift. So by treating the platysma and also the attachment, and we've learned that the attachment is not only inferior to the mandible, but also superior to the mandible. So you can treat, in both areas, depending on how much you have to work with. But if you're trying to improve jawline contour, that can definitely help. So you can also treat necklace creases with neuromodulator, and it's similar to platysma where it's just like 1 to 2 units all along the crease. And you can combine that with a HA filler. Again, you want to use a low G prime filler, and I'll even dilute that with saline or lidocaine, either one. And you can do a serial puncture technique or linear threads, but you get an instant result with the filler, and you can combine that with the neuromodulator. And then more static rhytids you can address with resurfacing, but be careful on the neck or anything off of the face. You want to use more conservative settings. And so you want to turn down your density and use a lower fluence because neck skin is thinner and there's fewer adnexal structures, so it's more prone to scarring. So you don't want to use the same setting that you do on your face as you do on the neck. For procedures that have delayed gratification, like non-invasive tightening. So non-invasive tightening generally takes at least a month to see any difference and continues to improve for 6 months because that collagen remodeling takes some time. So I like to give patients something that's immediate at the same time. So something like filler, because they'll see immediate improvement while they're waiting for their true results. So this was an example of bipolar radiofrequency in combination with filler on the same day. And you can see how she has some immediate improvement. And so while she's waiting for the bipolar RF to kick in, she'll be happy because she can see a difference already. Yes. Yeah, and so this was a study of ultrasound and calcium hydroxyapatite and HA fillers. I guess you have to think about like the device that you're using. So if you have the option, I would go device first and then filler. But if you're going to cause swelling, then filler first, then device. But something like, say, microneedling RF, where you have the needles that are penetrating the skin pretty deep. They've shown that you can dissolve filler in that way. And so in that case, I would prefer to do the microneedling RF and then do the filler, or just separate it on like a different day. But you have to think of like placement of the filler and then where your device is going. So if you're using something that's placed deeply and then you're using like a superficial laser that's only going like a couple, 100 microns or something, then it's not an issue. So I guess it kind of depends what we're talking about, but yeah. So this study was looking at microfocus ultrasound, and they showed that they didn't dissolve the filler, but you can also visualize where the filler is using the ultrasound technology. And so you can kind of avoid firing directly over the filler if you see it. But it is safe to combine. You just have to think about it logically, like what depth is each device going to, and then where are you placing your filler. So, but we can safely do it at the same time. So if we're talking about hand rejuvenation, you can use lasers to address pigment. And then I like to use calcium hydroxyapatite to address volume loss. And so here I'm using the cannula technique. And so I'm using a 22 gauge cannula. I'm creating the ports here. The on-label indication is to just inject boluses and massage them, but I find that you don't really get even distribution in that way. And then there's more swelling. I like using the cannula because it looks nice and even. You don't have to massage a lot. And I do reconstitute the calcium hydroxyapatite with 1 cc of lidocaine, so it is thinned out, and then it's easier to kind of spread. I'm careful not to like overfill the hands. You don't want the hands to look too puffy. You don't want anything to look too puffy in general. So I'd rather undertreat than overtreat. And so here's a before and after, and you can see that we might be able to put a little more if she wanted it, but that's a pretty nice improvement. Looks totally natural. No one would ever know. And here's another example. So to conclude, using a multimodal approach gives you the best results. And sometimes when you combine these modalities, it can obviate the need for more invasive procedures, things like facelift, which is becoming more popular these days. Fewer patients want surgery, more patients are looking for more non-invasive treatments. Okay, any questions about that? Yeah. Mm-hmm. It actually doesn't go 300 microns when you're using fully ablative resurfacing. It only goes 100 microns at a time, at least our device. I think most devices won't go that deep with fully ablative just because there's more risk of scarring when you deliver that much heat all at once. And with the single spot, I actually do several more passes. So I end up going 600 microns at the vermilion, and then I kind of feather out to maybe 300 microns closer to the medial cheek. So the vermilion can handle like a higher or a deeper depth compared to like the cheek and the rest of the face. Oh, so I don't really worry about patients using anything prior to laser. It's more just the aftercare. So if they use retinoids or their serums like the day before the procedure, that's not an issue for me. It's more about post-treatment, and I have them avoid that depending on the type of treatment. So for either a week for most procedures or something aggressive like fully ablative resurfacing, like for 3 months, they'll hold off. Yeah. Okay. So combination approach to melasma. So as we know, melasma is very stubborn and difficult to treat and has many triggers, primarily the sun. And then also there's a hormonal component. So if they're on oral contraceptives, then I usually ask them if it's an option to come off of them. If it's not an option, then we just, are fighting an uphill battle, and that's fine. We can get them better, but it does make it more resistant. Even IUDs that are like locally eluting, I do find like things like Mirena still cause melasma. So even when they're locally eluting, that's still something to consider. And it always requires long-term maintenance. So I can't cure melasma. I can only make them better. And so we use a combination approach. We use bleaching agents. You can use chemical peels, microdermabrasion, lasers, but most lasers make melasma worse. So only certain lasers that are like low energy, low density, because you don't want it to rebound. And then there's oral medications like tranexamic acid really has changed everything. This patient actually had ochronosis from chronic hydroquinone use, so it's important that patients understand that they can't use hydroquinone every day. And this is just anecdotal, but I tend to see ochronosis from prescriptions that were like in foreign countries. I've never actually seen it from prescriptions from the US, but not that it's not possible. So it's important that patients have a non-hydroquinone so that when they take their break from hydroquinone, they have something that they're always using. So there's a whole list of things that are available. This particular study looked at a non-hydroquinone skin brightener formulation using SMA 432, which is a prostaglandin E2 inhibitor, and it was found to be as effective as 4% hydroquinone. I personally don't use 4% hydroquinone. I use 12% hydroquinone. So, the non-hydroquinones are not as strong as the high concentration hydroquinones, but it's still valuable because patients can't use hydroquinone daily. This is one of my, favorite non-hydroquinone brightening serums, which contains topical tranexamic acid. Topical tranexamic acid is not going to be as effective as oral, but is still effective. So some patients actually don't want to use hydroquinone. They're worried about like skin cancer or things that they hear on the internet. So a lot of patients really don't want to use that these days. And this particular formulation showed a 22% improvement in the appearance of pigmentation. But it's just nice to have something that they can use daily. So whatever your preference may be. So this was a study that looked at melasma and non-ablative fractional resurfacing, and the study actually showed 75% improvement. But what we now know is that when you try to use this high of a density, you're going to have rebound. So they might look better for 3 to 6 months, and then they're going to rebound, and then it's going to be more stubborn. So I never use things like IPL or just regular non-ablative resurfacing at high densities because they're going to look better initially, but then it's more difficult to treat them down the line. So I prefer low energy, low density. This is my treatment of choice. I like the 1927 nanometer, and I usually do like 3.75% setting, but then I'll do like double the passes you're supposed to deliver. So I guess I end up doing about 7%. But I've never seen rebound in my patients when you use low density. And then we now know that there might be a vascular component to melasma. So if you see telangiectasias, they've shown that if you combine low density fractional resurfacing with vascular laser, you can actually get further improvement because they think that maybe it's causing like some inflammation. But a lot of patients with melasma, you'll notice that there is a vascular component, so you want to address that as well. And this was a study done by Ariel Kavar looking at microdermabrasion and low fluence Q-switch Nd:YAG. So it's such a low fluence that there's no endpoint, so no whitening. And then she combined it with a skincare regimen and found remissions last several months. This study was done in New York, so there's less sun than there is here in San Diego. I don't find this as effective, but you know, there's not one way to treat melasma, so this would be an option if this was the device that you had. I agree, yeah. So you can do picotoning too. So picotoning is using a picosecond laser at low energy with like multiple passes, and there's minimal downtime. It doesn't require any kind of anesthesia. So you have to think about that too. These patients are coming in monthly for their treatment. So if there's like a week of downtime every month, that's not very practical for patients. So something like this where there's very minimal downtime can be effective. This is before and after from Kelly Stankiewicz. And then this was a study that we did with one of the residents here using the 1064 nanometer Nd:YAG laser with the 650 microsecond pulse duration. We use low energy modes, and again, it doesn't require anesthesia, no downtime, and we did see about 26 to 50% improvement as early as 3 weeks after the treatment. So it's another option. This patient I still see, and she's kind of difficult to treat because she's outdoors a lot, but she was on tranexamic acid and a bleaching serum and the 1064 nanometer laser. And so we saw some improvement in her. One thing that I like to use is clobetasol. So clobetasol in clinic, I use it all day long. If I'm worried about PAH or melasma or even swelling, I just apply one application immediately after the laser. They don't have a prescription for it. It's just applied in clinic, and that can help prevent the risk of hyperpigmentation or making their melasma worse. And then oral medications have really changed our treatments. So Polypodium leucotomus is very helpful. So it's a fern extract, it's a water fern, and it has antioxidant properties. You can think of it as like an internal sunscreen, I tell patients. So it doesn't necessarily replace your sunscreen cream, it's just in addition to. And there was a study looking at 40 Asian patients who were randomized to either placebo or the Polypodium leucotomus, and then they were put on a bleaching cream. And so the patients who were on the Polypodium had greater improvement than patients who had the placebo. And so for my melasma patients, they take it daily. It's pretty benign. There's really not many side effects. You can get it on Amazon, so that's pretty helpful. But the game changer really has been tranexamic acid. So tranexamic acid is normally prescribed for menorrhagia. The doses that we use are much lower than what's prescribed for menorrhagia, but essentially, so by taking it, it's going to increase your risk for thromboembolism because it's a procoagulant, but it can mitigate UV radiation-induced melanogenesis and neovascularization, and that's how it helps for melasma. And so there was, I followed tranexamic acid for a long time because they were using it in Asia many years ago. And I started hearing about it maybe like 10 years ago, but I was scared of the clotting issue. But once this study came out, I was more comfortable. And so now I just keep my patients on it indefinitely. So there was 561 melasma patients, and only one patient developed a DVT, and they actually had an underlying protein S deficiency. And so none of the other patients had any issues. Some complained of abdominal bloating and pain, but none of my patients ever complain of that. So I think it's pretty safe. It's over the counter in Asia. I'm not really afraid of it anymore. I have my patients stay on it. I used to do like a 6-month course and have them take a break, but now they're just on it indefinitely because when you come off of it, the melasma comes back. But it is the most dramatic improvement that I've seen. So I'm less frustrated with melasma because of tranexamic acid. So the dosing is 650 milligrams daily. We used to say do 325 twice daily, but then you have to cut the pill in half. And the study showed that 650 was just as effective. And I agree with that. And I don't do any kind of like lab workup. I just make sure that they're not on birth control because that's going to increase the risk of clotting and make sure they don't have any other increased risk of clotting, like if they smoke or current malignancy or any kind of like clotting disorder. But I just asked them, so it's just an oral history. So my approach is broad spectrum SPF, polypodium leukotomas daily. I use 12% hydroquinone and 6% kojic acid in Versabase. And the Versabase is really what makes it tolerable to use 12% hydroquinone. So that's how it's compounded. And then they take a pea-sized amount, mix it with a moisturizer, and put it on the whole face. It's too strong to use as a spot treatment. You can do glycolic peels or low energy lasers and then tranexamic acid, and that really helps the most. This I do, yeah. I usually say like 2 to 3 months on, 2 weeks off, 2 months on, 2 weeks off. And then once they're happy with their improvement, then they can just use it like once or twice a week. And if they're not using it daily, then they can just use it like that indefinitely. And so this was actually only after one laser treatment, but I think the tranexamic did all the work. And then, so my patient with ochronosis, I couldn't use any bleaching cream. So we used the 1927 and tranexamic acid, and she looks a lot better just getting rid of her like melasma and discoloration. But this was like confirmed ochronosis. I think she was referred from UCI. Okay, so melasma is chronic, and combination treatments really achieve the best results, but counseling is key because it's important that patients understand that there is no cure for this. We can only improve them, but it's going to come and go. Okay. Any questions on that? Yeah. Yeah, I mean, whatever you're comfortable with. If you want to start them on tranexamic and hydroquinone, then, you know, patients do pretty well with that. The laser does speed recovery, to, you know, somewhat. So if they want to be doing everything possible, then you can kind of send them over. But if they can't afford the laser or they don't want laser, then that would be a good place to start. Yeah. And then, so we use University Pharmacy to compound, and they have our recipe. So it would be pretty easy for you to send a prescription there. Okay. So we'll finish with scars. We have till 11, is that right? Yeah, okay. Okay, so it's important to manage expectations with scars because I can't erase scars. We don't have the technology to erase scars. We can only improve them and make them less noticeable. And it does take multiple treatments. It takes time to see the improvement. There is downtime with it, and it can be an investment. So it's important that patients understand this before we start. And everyone always asks, when do we start treatment for scars? And actually, there's a study that showed that the earlier you start, the better. So I like to laser at suture removal if that's possible. And I think a lot of the surgery literature is kind of dated. So a lot of patients don't get referred till like a year later because that is what we were taught previously. But we now know that as soon as you can treat, then we see better results. So at suture removal is ideal. And then there's different types of scars. So there's red scars, hyperpigmented or hypopigmented, atrophic, hypertrophic, pincushion, keloid scars. And so we're going to treat each of these scars somewhat differently. And so most scars require multiple modalities. So if they're red, you want to use a vascular laser first, because if you use another laser, like a pigment specific laser first, then that's going to exacerbate non-specific erythema, and it's going to be hard to tell where the erythema was. So vascular laser first, then pigment, then resurfacing, and then if they need filler, I usually will do that afterwards. So red scars do fade with time, but sometimes they can take several months to fade. And so laser will speed them up. You can use KTP, you can use PDL, you can use IPL. There's multiple studies that favor low fluence, short pulse duration for scars, but there's varying studies. So you can use a PDL, which not only improves erythema, but it also has been shown to induce collagen remodeling. So the heat diffuses into the surrounding dermis and results in increased TGF-beta, which stimulates fibroblasts, compared to the 532 nanometer laser, which doesn't penetrate as deeply. So it's not as effective for collagen remodeling, but head-to-head studies show that in terms of erythema, it's just as effective as the pulse dye. So here's an example of non-ablative resurfacing and vascular laser for acne scarring. I showed you this guy already. And then in terms of like pre-treatment, so if you have like hyperpigmented scarring or you're worried about hyperpigmentation, Tina also did this study showing that if you pre-treat with hydroquinone to prevent hyperpigmentation, it's not really effective. So you might hear about pre-treatment. I generally just post-treat with hydroquinone if I'm worried. I don't worry about pre-treating. And then I mentioned clobetasol can help with post-inflammatory hyperpigmentation if you're worried about that. And we talked about tranexamic acid for hyperpigmented scars. This can be helpful as well. Hypopigmented scars. So you can repigment scars sometimes by using fractional lasers. And the idea is by removing the scars, the melanocytes can like migrate in, start to repigment. So I have seen that, but it's not guaranteed. And you can combine that with topical bimidapros. So normally we think of that as for growing lashes, but it has been shown to help stimulate melanin production. And so for hypopigmented scars, I will do a combination of resurfacing plus topical bimidapros, and they apply that twice daily for several months. And again, that increases melanogenesis. So atrophic scars, you can think about subcision, lasers, fillers, needle RF. One trick that I like is when you spread the skin, if it improves, then the atrophic scar will respond to lasers. But if it doesn't really improve when you stretch, then it's being tethered down by scar tissue, and that will require some subcision in order to improve the atrophy. So you can use subcision with like a no-core needle. Sometimes I actually just use a regular 13 gauge needle on a syringe with lidocaine. And so I'm injecting lidocaine as I'm subcising, but it's going to take multiple treatments. So it's not a one-time treatment. It's going to take several monthly treatments to see the improvement. When we're talking about fractional lasers, you want to use low density for scars. So scars are prone to scarring. So if you try to use aggressive settings, that can increase the risk of scarring. So you want to use low density. So just to remind you, your fluence is going to determine your depth. So you're going to use a high fluence if you have a thicker scar, or you can use a lower fluence if you have a thinner scar, but your fluence is going to determine your depth, and your density is your aggressiveness. So I use less aggressive settings when I'm treating scars. So that's generally like under 15% or so, but it depends which laser you're using. So this is someone who I treated with a fractional ablative laser on the day of suture removal. And I believe this was after only one treatment, but we did a second one just to be sure. So sometimes we can get pretty close to erasing them. I just don't like to say that because everyone heals differently. This is another one that we did on the day of suture removal, and this was after one. So you can still kind of see it, but it's, it's pretty subtle if you can catch them early. So hypertrophic scars, you can use fractional ablative lasers and laser-assisted drug delivery. So essentially, the ablative laser is creating these channels where you can deliver drugs into the skin. The rule is don't apply anything that's not meant to be injected into the skin because it can cause granulomatous reactions. So you'll hear, side effects to vitamin C serums that are being delivered transdermally, but I'll generally use like triamcinolone or 5-FU, but only things that are meant to be injected. And so here I'm using low density. So I think I'm at 5.5% here. And then immediately after you're going to apply, I applied topical Kenalog and then 5-FU. And the channels stay open for 48 hours. So it does increase the permeability of other medications if they're taking something home. But I generally apply it immediately after. If it's really thick, then I'll also inject as well. I'll do both. So this was before and after. I think we did 2 treatments on this one. So for contracture scars, Nicola was with me yesterday. This was our patient from yesterday. So not only are you improving the appearance of scars, but what I love is that you can also improve function. So immediately after treatment with the laser, patients with contracture scars will actually like feel the difference immediately because you're vaporizing the scar like in real time. And so immediately after, they have improved mobility because you're kind of removing a portion of that scar. So you can see she's able to open her hand a little wider immediately after. So fillers you can use for atrophic scars. You want to use semi-permanent fillers or temporary fillers. You don't want to use permanent fillers. So there's polymethyl methacrylate that's actually FDA approved for acne scars, but that can cause granulomatous reactions. So I personally would recommend not using that. And I like to use low G prime fillers in this case. So this was a chickenpox scar, and the filler is supposed to only last 6 months, but in this case, it lasted several years. So I usually promise about 6 months, and if they get more time out of it, then great. Botulinum toxin, this was something that Reed and I looked into extensively. And so the thought was that botulinum toxin may reduce skin fibrosis by decreasing fibroblast proliferation, by modulating the activity of TGF-beta. So we were hoping that monotherapy might be able to treat keloid scars, but it was not very dramatic or compelling. And so really, I think that it's better in combination, and it's better to prevent hypertrophic or keloid scars because you're removing the tension. So this was a patient that I used a combination of vascular laser, fractional erbium, Kenalog 5-FU, and botulinum toxin, and she did well. You can use botulinum toxin alone. It works very well on the forehead because they're not contracting or moving, so it just releases the tension. And then ice pick scars are not really amenable to laser treatment, so you want to use either punch excisions where you use like a 2 millimeter punch to actually remove the scar, or you use cross technique, which is chemical reconstruction of skin scars using high concentration TCA. So usually I'm using 100%. You want to just take like a toothpick or a CTA, and I like snap it so that I get a point. You want to go right in the center so that the walls close. If you get it like outside the ice pick scar, it can potentially open it. So you want to make sure you're right in the middle so that it closes, and then you can laser over it immediately after. So once you see the whitening, you can laser over it. And that's similar in efficacy to the punch excision technique. So when you punch out the scar, you're basically changing it to a different type of scar that is more amenable to laser treatment. So to conclude, I mean, really with everything, we're using a multifactorial approach. In general, we always want to treat redness first, but it's important that you set realistic expectations because I can't erase scars. I can only improve them. Thank you.